All right, today we're jumping into one of the most critical conditions you'll ever encounter in medicine, circulatory shock. This is where the body's entire life support system starts to unravel in a terrifying cascade. And, understanding this isn't just an academic exercise. It is, quite literally, a matter of life and death.
This quote just nails what makes shock so incredibly dangerous. It's not a single bad thing happening. It's a vicious cycle. The body gets hit with an initial problem, and its attempts to fix it just fail. It creates this feedback loop where the damage feeds on itself, getting worse and worse until it just can't be stopped. So, at its most basic level, what are we talking about? It's a delivery failure, plain and simple. The circulatory system just can't get enough oxygen-rich blood to the body's tissues. And without that oxygen, cells start to shut down and die. If you don't stop it, that leads straight to multi-organ failure. Now, shock isn't like flipping a switch. It's a progression, and it's a terrifying one. At first, the body does everything it can to compensate, to keep things running. But eventually, those defenses get overwhelmed and the system starts to decompensate. From there, if you can't intervene, you hit an irreversible stage where the damage is just done. The clock is always ticking.
Okay, here's how we're going to break this all down. We'll look at the four main types of failure. We'll dive into what we call the empty tank, or hypovolemic shock, and the broken pump, which is cardiogenic. Then we'll cover obstructive and distributive shock, and we'll wrap up with why matching the treatment to the cause is absolutely everything.
So the end result of shock is always the same thing. Not enough blood flow where it needs to go. But there are four totally different ways you can get there. And figuring out which path the patient is on is the key to everything.
The easiest way to wrap your head around this is to think of it like basic plumbing. You've got a pump, that's your heart. You've got fluid running through the system, that's your blood volume. And you have the pipes that carry the fluid, those are your blood vessels. Shock is what happens when one of those three things fails.
So here they are, the four types, each one tied to a failure in that plumbing system. And right away you see something that might be a little surprising. Distributive shock, a failure of the pipes, is by far the most common, making up almost 2/3 of all cases. We'll get to that one, but first let's start with a failure of the fluid.
This is probably the most intuitive kind of shock. The name really says it all. Hypo, meaning low, and volemic, meaning volume. The tank is just running empty. So the key here is that the heart could be pumping perfectly, and the blood vessels could be totally fine, but there's just not enough fluid, not enough blood or plasma to go around. This could be from something obvious, like a major hemorrhage, or from something less obvious, like severe burns or dehydration, where you're losing a ton of fluid.
And this right here is a perfect example of why you have to know what you're dealing with. In hypovolemic shock, the body tries to compensate by clamping down its blood vessels to raise the pressure. That makes the skin feel cool and clammy. But in distributive shock, the exact opposite happens. The vessels open wide up, making the skin warm. Same core problem, low blood pressure, but presenting in two completely opposite ways.
Which of course leads to a really logical question. If the blood pressure is tanking, why can't we just give a drug, a vasopressor, to squeeze the pipes and bring the pressure back up? Well, because that would be a critical error. The problem isn't the size of the pipes, it's the fact that there's nothing in them. Using a drug to squeeze them is like flooring the gas pedal on a car that's out of fuel. You're just going to damage the engine. You're squeezing empty vessels and starving the organs even more. You have to replace the volume first, period.
So how do you refill that tank? The first move is all about this number. The guidelines call for an immediate fast infusion of 30 milliliters of fluid for every kilogram of the patient's weight. That is step one, and it is the most important step. Okay, let's switch gears to the next failure. What happens when the fluid level is fine, the pipes are fine, but the pump itself just breaks down? Well, that's cardiogenic shock.
The number one cause here is a massive heart attack, one that damages so much heart muscle that the heart just can't physically squeeze hard enough to get blood to the body. The tank is full, the pipes are good, but the engine has seized.
And this is another one of those absolutely critical distinctions. Remember that life-saving flood of fluid we just talked about for the empty tank? If you do that to a patient with a broken pump, it can be a disaster. The failing heart can't handle all that extra volume, so the fluid backs up into the lungs, and the patient essentially starts to drown. One treatment saves a life, the very same treatment can end one.
So in this case, since the pump is the problem, use medications to help the heart squeeze harder and to support blood pressure. And the key number that clinicians are shooting for is a mean arterial pressure, or MAP, of at least 65. That's considered the minimum pressure you need to keep blood flowing to the brain and kidneys.
All right, on to our last two categories. They're a bit less common, but they are every bit as deadly. We're talking about a physical blockage stopping blood flow, or a situation where the pipes themselves get leaky.
Obstructive shock is exactly what it sounds like. Something is physically blocking the heart or the major blood vessels. The classic example is a tension pneumothorax. Air gets into the chest cavity and builds up so much pressure that it literally crushes the heart from the outside, so it can't fill with blood. No amount of fluid or drugs is going to fix this. You have to get in there and release that pressure. And finally, we've got distributive shock. In this case, the pump is working, the volume is there, but the pipes, the blood vessels, are the problem. They lose their tone, they get massively dilated and leaky. Suddenly, the vascular system is so big that the normal amount of blood can't even come close to filling it, and the pressure just plummets. And the number one cause of this is a massive system-wide infection, which we call septic shock.
And let's be clear, when we talk about distributive shock, we are overwhelmingly talking about one thing: sepsis. As you can see here, it's the dominant cause by a huge margin. Yeah, other things can cause it, like a severe allergic reaction or a major spinal cord injury, but they are much, much rarer.
So this brings us all the way back to the single most important principle here. You have to use the right tool for the job. A one-size-fits-all approach to shock isn't just wrong, it's incredibly dangerous. It really all comes down to this. If the tank is empty in hypovolemic shock, you fill it. If the pump is broken in cardiogenic shock, you support it. If there's a physical blockage causing obstructive shock, you have to relieve it. And if the pipes are leaky and dilated from sepsis, you give fluids, you hit the infection with antibiotics, and you use vasopressors to get some tone back. 4 different problems, 4 completely different solutions.
So we're left with this final thought. When you're faced with a circulatory system that's completely collapsing, the biggest challenge isn't just knowing what all the answers are. It's about figuring out, fast, why it's happening. Is it a fluid problem, a pump problem, a pipes problem, or a blockage? Because when that clock is ticking, asking the right question is the first and maybe the most important step to finding the answer that saves a life.